We are going to be discussing the application of the health belief model on an opioid use health behavior. We are the purple group. The members of our group are Abigail Chesterton, Kelly Harper, and Eden Lackner. And this is for Public Health 606 with Professor Dr. Lori DeWald. The health belief model grew out of the need to identify determinants of tuberculosis screening. This theory was created by social psychologists working at the United States Public Health Service. During this time, diagnostic tools for diagnosing tuberculosis were underutilized because most people with the disease did not realize it. Initially, the health belief model focused on increasing awareness and concern about preventable health problems. Green and colleagues discussed the initial theory, proposing that individuals are afraid of serious illness and that healthy habits are a product of perceived threats and self-efficacy to take action. Individuals decide whether psychological barriers overtake the benefits of behavior change. The health belief model is considered a value expectancy theory because the primary constructs are based on the idea that behavior change happens after benefits remain when accounting for the costs associated with that change. The health belief model is proposed to be the most widely used conceptual framework in health promotion programs. Rosenstock is quoted referencing the health belief model by saying, "One's daily activities were thus conceived of as a process of being pulled by positive forces and repelled by negative forces." Two main constructs of the health belief model are perceived threat of a health behavior and perceived benefits of making a behavior change. The likelihood of engaging in a health-promoting behavior results from an individual perceiving more gains with making the change despite costs. DeClemente and colleagues discussed that theories like the health belief model result in change when an individual is able to maximize their outcomes while incurring minimal costs. We will now discuss the constructs of the health belief model. The primary constructs, according to Rosenstock, include perceived susceptibility, perceived severity, perceived benefits, and perceived barriers. Rosenstock outlined the four constructs by stating that an individual will engage in preventive behaviors if they believe they are personally susceptible to the condition, they believe that having the condition would have at least moderate severity on an aspect of their life, they believe that taking preventive action would be beneficial to their health and reduce their susceptibility to the condition, and they believe that there are few barriers to taking preventive action. Perceived susceptibility, perceived severity, and few perceived barriers can produce motivation to change, but Rosenstock suggests that this can still result in stagnant behaviors. An individual's readiness to make behavior change results from the combination of perceived susceptibility, benefits, and barriers. When a person is ready to change, cues to action prompt actual behavior change. Coaching and education can have a strong impact on self-efficacy, helping to increase someone's perceived ability to facilitate behavior change. These two additional constructs can be very important in influencing if an individual changes behavior or not. Health habits are not formed solely by an individual independent of other factors. Because of the crossover between individual, social, and cultural factors, the impact of these modifying factors on behavior habits must be considered when creating behavior change interventions.
I will discuss the implementation of the health belief model for effective behavior change. Common methods used to implement the health belief model within the field of substance use treatment, more specifically in treating opioid use disorder, are the socio-cognitive approach and cognitive behavioral approach. The socio-cognitive approach focuses on pro-social and interpersonal behaviors like empathy and emotional recognition. Researchers have used various tests and assessments like the multifaceted empathy test, the movie for the assessment of social cognition, and comprehensive effect test system to find that persons with substance use show distinct deficits in socio-cognitive functioning. Through the health belief model, education can help individuals recognize that these deficits are crucial for everyday life and encourage action towards regaining those cognitive empathy skills. Utilizing the cognitive behavioral approach to address stress management to decrease relapse has been found through the researchers, Mione and colleagues. They found that substance users should believe that stress is a large factor in risk of relapse. Their intervention was educational and emphasized that substance users should believe stress affects their recovery, denial of opioid use, and can interfere with relationships. Following the health belief model, this study supports and emphasizes that family and health professionals of the individual are considered as cues to action.
Next, we'll go ahead and discuss the evaluation and critiques of the health belief model. So the health belief model is a straightforward method of predicting behaviors based on key beliefs. This model is widely used and allows researchers to understand what may keep someone from participating in health promoting behavior. Along with the applicability to both long and short-term interventions, a lot of research has been performed assessing the effectiveness of the health belief model. While this model is quite popular, it does have its limitations. Lamort, MD, PhD, and MPH just details a few in his article on the health belief model. These include how the model does not account for determinants that can influence one's acceptance of a behavior, or external factors that may influence the ability to adopt a behavior. Along with this, the health belief model assumes that knowledge is equally accessible, which is not always the case. There are critiques on the application of the health belief model, along with gaps identified in what the constructs address. Shadu and colleagues note that because the model focuses on the individual, it cannot be used alone, since there are also external factors that affect decision-making. So the health belief model should be used with other models to account for these additional factors. Connor comments on how the components of the health belief model are often tested independent of each other, and how they are essentially different versions of the predictors used. Depending on the study that you read, researchers may or may not have included either the perceived barriers or cues to action. Lastly, the health belief model does not account for habits. Habitual behaviors can influence the individual and make it harder to adopt new behaviors, which in turn would impact the intervention requirements.
So some other methods to achieve effective behavior change, the social learning theory revolving around learning behaviors and attitudes from a social context and interactions. Researchers Cruz, Seo, and Kim explain that social interactions have a large effect on attitudes and behaviors related to substance use. Programs that provide peer support are found to be effective within the field of relapse prevention. This could be beneficial in encouraging the use of fentanyl testing strips if guided by positive peer support. The information motivation behavioral skills model was noted in the literature by researchers Cooperman and colleagues, who describe that an individual can change their behavior when information, motivation, and skills are available to them. Interventions were found effective in increasing efficacy of behaviors related to substance use across a variety of health behaviors. Thank you for your time. We would appreciate any feedback or comments. Please view the next two slides for our references.